So thank you everyone for coming today. This is the Tennessee Center for AIDS Research seminar series, our monthly chance to bring in speakers on high priority topics related to HIV and other infectious diseases. So we're delighted today to have Dr. Carolyn Wester, I think is known to many people on the call, as our speaker for today. And Dr. Wester has had a varied and very distinguished career, stretching across academia, across the globe, and then into state and federal government as well. She received her medical degree from Dartmouth School of Medicine, and later her Master of Public Health in Qualitative Methods from the Harvard School of Public Health. And she has held a variety of positions, including Research Associate at Harvard, Director of Urogynecology and Pelvic Reconstructive Surgery at Cook County Hospital in Chicago, and she was also an attending physician at Rush Center for Women's Medicine in Chicago. But in 2000, she and her husband, Bill Wester, I think many people know as well, packed up and moved the entire family to Botswana, where she was a principal investigator or co-investigator on a number of very important early trials in the field of HIV, including the country's first randomized controlled trial, which was in the area of prevention of mother-to-child transmission of HIV. And then in 2008, she was recruited to be the medical director for HIV, STDs, and viral hepatitis at Tennessee Department of Health. And under her leadership, the department launched and expanded the viral hepatitis program, increased funding by about double, and then tripled staff, and also rolled out viral hepatitis surveillance, testing, prevention, and treatment across the state. So really a revolutionary change in viral hepatitis for Tennessee. And this then, I think, led to a subsequent recruitment to the position she currently holds, which she started in 2019 at the Centers for Disease Control and Prevention as the permanent director of the Division of Viral Hepatitis. So I'd like to welcome Dr. Wester today, who will be giving her talk, Viral Hepatitis Elimination in the United States, Progress, Priorities, and Opportunities. Thank you so much for coming.
Great. Well, thank you so much, John, for you and David for the introduction, and also just the opportunity to be here. And it's so nice to see a number of you in the room. I know there's others online, but this is like coming home in a lot of ways. The CFAR, whether I was at Tennessee Department of Health or working with you all, obviously the connection with Bill, my husband, but also as you guys stood up and expanded the CFAR, Meharry and Vanderbilt had obviously been the bedrock of that. But then to open the partnership to the Tennessee Department of Health and be have the opportunity to participate in that way was really a wonderful opportunity and a win-win, I think, all the way around. So appreciate the opportunity to come back. I will, as John mentioned, just be speaking over about the next 25 or 30 minutes about viral hepatitis elimination in the United States. And do I use the keypad here or just the mouse right click?
You should be able to do that.
Great. So I have no disclosures, and I will be mentioning a few diagnostic products, but obviously not intended to imply endorsement by myself or obviously my employer. We'll look a little bit of background. I thought it might be helpful to have an idea of how, where the Division of Viral Hepatitis is within the U.S. Centers for Disease Control and Prevention, and look at a little bit of our national hepatitis elimination goals, and what we even mean by elimination. Progress towards elimination, will then be looking at some of the data and trends, and then looking forward how we can accelerate. In terms of background, the CDC, the Centers for Disease Control and Prevention, is organized under our agency director, currently Dr. Mandy Cohen, into 12 national centers that are organized into 4 groups: infectious disease centers, non-infectious disease centers, also public health science and surveillance, as well as public health services and implementation science. Our Division of Viral Hepatitis lives within one of the infectious disease centers, the National Center for HIV, Hepatitis, STD, and TB Prevention, under the leadership of our director, Dr. John O'Merman. Our division is one of the smallest of the divisions. We have about 110 FTEs, about 20 fellows, and we're organized into 3 branches. So besides having kind of an Office of Science, Policy, Communications, and a global unit, since we don't have direct appropriations for global, unlike TB and HIV. So we have a lot of things. And then our 3 branches are where a lot of the work with our partners and programs happen. And that's episurveillance, prevention, and then also our laboratory branch. We lean into a lot of different areas. From public health, we're providing leadership in science and public health practices to control viral hepatitis through monitoring disease trends, detecting and responding to outbreaks, and also supporting partners, both local and state health departments, as well as tribal and territorial, to conduct disease surveillance, but also those health departments and other partners, community-based and other federal entities in viral hepatitis prevention, diagnosis, treatment, and particularly in the context of disproportionately affected populations and what we call high impact settings. We're advancing research, developing, promoting national testing and vaccination recommendations, and increasing public awareness. And I'll try to feed in some examples of that. So it's a big job for a small division, and you'll see with small federal appropriations, there are millions of people estimated to be living with chronic hepatitis in the US. Unlike globally, the US and other high-income countries have more of a mix of C than B, and that you'll see is attributed to really successful vaccine strategies for several decades now in infants and adolescents. But for the over 300 million people globally living with viral hepatitis, most countries have a disproportionate burden of B, so a huge opportunity. In the US, we still see about 85,000 estimated acute infections each year, and that is predominantly among reproductive age adults in association with drug use, and the lion's share of that is with C in the US. Since more than half of C acute infections turn into chronic infection, and because reproductive age adults are disproportionately impacted, it's not surprising that we're seeing multiple generations impacted. I mentioned we have modest and level appropriations. In the purple bars, our federal appropriations are $43 million. That was about a cut of a quarter of the budget that we had at the Tennessee Department of Health when you included the Ryan White budget. It is crazy, the disparity in terms of need, opportunity, breadth, and magnitude of what we're supposed to be covering and what ours are. Just to put it in perspective, our appropriations are about 5% of what I would say are more right-sized appropriation for CDC's HIV prevention program. And that doesn't even include Ryan White or PEPFAR. We do get some supplemental funds from our center, which are in the blue. Those are what we call IDO funds, or infectious disease consequences of the opioid epidemic. Those funds have only been streaming through in 5 years. And those are fund our harm reduction portfolio, which I'll share with you. These are all appropriated once a year. We're not big enough to have a big target on our back, but you know, it is year to year appropriations, and you can see we haven't really had much of an increase. Obviously, everybody's work needs to be kind of informed by a strategic plan. Ours is particularly critical because we need to know what's going to be feasible within the resources that we have, what's going to be the most impactful. And I will say we are very adept at partnerships, both within CDC and also outside of CDC. So within CDC, the National Center for Injury Prevention and Control, which is really looking at drug overdose prevention and work among people who use and inject drugs, is a big partner. Also, the National Center for Injury for Immunizations and Respiratory Diseases, because both Hep A and B are vaccine preventable. Those are just some examples of the partnerships that we have internal to CDC. Our outcomes, so we have 4 main goals: reduce new infections, reduce related mortality, reduce viral hepatitis related disparities, and also because our surveillance system was so rudimentary, when we established our new funding opportunity for health departments, we also have a goal to establish national viral hepatitis surveillance. Our outcome measures are really in line with WHO sector strategy goals, which are to reduce new viral hepatitis infections, and this is B and C, by 90% by 2030, and to reduce related mortality by 65%. So when we talk about eliminating viral hepatitis, we're talking about these goals, and it's really eliminating it as a public health threat. We also have an HHS plan, and then each year we release a progress report reporting on those goals. So what does the progress look like so far? Well, before I get into the data, and I'm going to present some data from surveillance data and vital statistics, I just wanted to identify that there's no single source that tells the whole story. So for acute, chronic, and perinatal infections, and we've got 7 reportable conditions, A, and then acute, chronic, and perinatal for B and C. Those really come from public health case reports. And that's why it's so important that we build that infrastructure across all 50 states, DC, and also some large cities in Puerto Rico. Viral hepatitis related deaths comes from vital statistics data. We also use that in our perinatal program. Viral hepatitis prevalence estimates, though, really need to come from different sources. And so we use national surveys, and we're also implementing a novel strategy, which was implemented during COVID to look at COVID antibody levels, but we're partnering with large commercial laboratories to use remnant samples to test for hepatitis C and then hopefully hepatitis B. And then developing, ascertaining treatment rates and developing care cascades. We look at often purchased data sets, looking at pharmacy and or medical claims data, and then again back to commercial labs for longitudinal laboratory test results. So while I'm going to focus primarily on B and C because those are the biggest, the highest burden, and also the 2 hepatitis that turn into chronic infection, I did want to mention just something about A, this is just a slide showing the burden of, B is vaccine preventable, C is curable with 8 to 12 weeks of treatment, and yet we're still seeing about 15,000 reported B and C related deaths in the US each year. And these are reported compared to actual is different, and it changes over time, but it's estimated that we capture about 50% of the actual related deaths. But I did want to pivot to A for just a second before I go into the progress towards elimination, because in some ways it's a real success, but it's also a warning signal. So for A, which is different than the other hepatitis, it's fecal oral transmission, and it's also vaccine preventable, so unlike C and unlike B and C in terms of transmission, but it's vaccine preventable, and we saw a lot of success in terms of reduced case rates. In fact, when routine vaccine was initially recommended in '96, we saw a 95% reduction in acute cases through 2011, which plateaued. And during that point, we were seeing mostly sporadic foodborne outbreaks. But something changed in 2016, and Tennessee actually was involved in this as well. But there was a 37-state outbreak of person-to-person Hep A cases. And when it was all said and done, there were about 45,000 cases with a 61% hospitalization rate and 1% death. So of course, although it doesn't turn into chronic infection, it does take its toll in the acute state. And the primary risk factors associated were basically history of drug use, injection and non-injection, and also homelessness. And we had a big cohort of unvaccinated adults. So it's just a warning sign that, particularly in B, as we'll see, waiting for a cohort to age up, you still got a very susceptible adult at-risk population. And the intersection of substance use disorder and acute infections is not just limited to the bloodborne and sexually transmitted infections. So I will now turn to kind of progress towards B and C. Because of the burden and magnitude of infections of C, I'm going to spend most of my time on that. But I did want to begin a little bit with B first. B is a little unusual. In the US, it's really a tale of 2 epidemiologies. For chronic infection, it's primarily among people who are born outside of the US and infected perinatally. And that's because when transmission is acquired as a newborn, you have a 90% chance of becoming chronically infected for a lifelong infection. Whereas if someone acquires infection as adult, they only have about a 10% chance of it becoming chronic infection. So people born outside of the US in countries where infant prophylaxis, routine birth dose vaccination, HBIG, and/or maternal treatment is not available, we'll see higher perinatal transmission rates and that lead to lifelong infection. Whereas in the U.S., as you'll see, we're primarily seeing new infections among unvaccinated adults with potential exposures. So again, a very evolving but successful vaccine strategy for Hep B in the U.S. as of 1991. So these individuals would be, 33 years of age now. Routine infant vaccination has been recommended. There was a catch-up vaccination series recommended among adults in 99, which would actually give protection all the way back to people born from 81 on. And then birth dose was introduced in 2005. And even with the addition of some risk factors among adults, we really saw a plateau, and we were still seeing about 15 to 20,000 acute cases in the US each year. And you can see that's after 2010, so concurrent with the opioid crisis really kind of picking up. I point that out because it informed updates in the national vaccine strategy. So if we break it down, what do those acute infections look like a little bit more in terms of age category and risk exposure? Well, it might be a little hard to see, but the arrows were meant to show the successes in the younger age groups with that infant vaccine coverage. So in the very light blue at the bottom, those are very low case rates in 0 to 19. And our 20-year-olds, it's the green, and then the dark blue is our 30-year-olds. But you could see that the highest case rates were among individuals in their 40s and 50s. So again, susceptible adults with risk factors, as you can see on the right, injection drug use with being the most commonly reported risk factor. Chronic infections, this is again where we get to our tale of two epidemiologies, a different story, older individuals, predominantly Asian Pacific Islander persons and also non-Hispanic Black persons, and not shown on this slide, but about 80% are individuals who were born outside of the US and then immigrated to the US. So this just is like our prevention efforts are going to be focused in different settings and populations than our diagnosis and treatment efforts. And this mortality is kind of a similar picture of what I just showed with chronic. So as we kind of put it into our report card, again, our 2025 strategic plan was built with 2030 goals, mimicking these. We're doing well with on the left with the acute infections, although we've got disparities by age group and geography. And we've got room to grow and to accelerate really for our B-related deaths. I will say our B-related deaths, so you'll see with C, it's about 6.5 times higher than our B. So this is just a summary of this. It'll be in the slide deck. I won't take your time because I think I just said that. So moving towards C elimination, how is it similar and how is it different? Well, we've also seen increases, but the increases have been much higher. So again, about 15,000 acute B infections a year, about 70,000 acute C infections a year. And this only shows part of the story. If you back that left graph up to start at 2010, it's about a 5-fold or 400% increase. Geographically, it's in some of the areas most hard hit by the opioid crisis. So again, highlighting the intersection of injection drug use. Similar to B, but punctuated and moved about a decade earlier, you can see the highest case rates are among individuals in their 20s, 30s, and 40s. So again, these are reproductive age adults, which risks a trimodal curve through perinatal transmission. Acute infections by rate, again, a smaller denominator, but are highest among American Indian and Alaskan Native persons. And also on the right kind of concern is that you can see in the brown, that was the rate of chronic and acute infections among non-Hispanic white persons, which reflected the opioid crisis. But you can see in the pink line over the last couple of years, there have been accelerated increase in non-Hispanic Black persons. So anyways, just an idea of like, where are our prevention efforts hitting and where are they not hitting and where do we need to be expanding? So because more than half of acute C infections turn into chronic, Not surprisingly, on the left, as I mentioned, we're seeing multiple generations. And then we're also seeing some of the racial ethnic disparities already described in terms of acute. With mortality, because of the course of natural disease progression, you see the mortality rates 2 or 3 decades pushed down the line, but the racial and ethnic disparities persist. And this just shows a progress report there. Again, a lot of work to do in the context of prevention, particularly among people who use and inject drugs, and mortality on track, but disparities and accelerated progress needed. So here's a summary of what I just said. I will skip over that. I wanted to move now a little bit in the way of, okay, DVH, with the resources that we do have, the Division of Viral Hepatitis, what are some of the ways that we've been trying to lean into, both recommendation-wise as well as programmatically, to address and alleviate these trends and disparities? Well, first of all, we've moved from risk-based to universal-based screening and vaccination recommendations in our adult populations. And I don't say this lightly. Each one of these is like a 2-year process, which is often following the cost effectiveness analyses that you need to do. And then you need to do a systematic review of the literature to look at all the benefits and harms, unintended consequences, et cetera. But bottom line is B vaccination is now recommended among adults 19 to 59 years of age. This was considered and ultimately voted on by the Advisory Committee on Immunization Practices, which has several members from Vanderbilt. B screening and testing recommendations similarly went from risk-based. We saw that plateau in, well, actually that was for vaccination, but new screening recommendations are all adults, at least 18 years of life, once in a lifetime. We're also recommending, we differ a little from AASLD and IDSA, but we recommend a triple panel, because with the triple panel, instead of just having a B surface antigen, you can also add core antibody and total antibody and see if the person's susceptible and in need of vaccination. We have also moved to universal screening recommendations. This was in 2020, the first of the 4 that I'm showing, for Hep C screening among all adults, every pregnant person, and anyone with risk factor, including periodic testing as risk persists. And then most recently, in November of 23, we updated perinatal testing recommendations, which used to be an antibody at 18 months of age because of persistent maternal antibody. You couldn't test before then, but now we're recommending an RNA test at 2 to 6 months of age. There was a lot of loss to follow up, and there's still a lot of challenges with this. Right now, only about 25%.
Hi, we can't hear you all.
Yeah, we lost volume.
Yeah, we lost volume.
Oh, has it been muted the whole time?
No, not the whole time. What did
No,
folks
no, just a
last
couple
see?
slides.
Is it mute again? Sorry. Can you hear us now?
Yeah, I would say 2 slides back.
2 slides back? Okay. Yeah, I'm not sure what happened. Yeah, I'll let you take over.
Great, thank you. So moving from national recommendations for testing and vaccination, some other ways that CDC is leaning into trying to advance elimination is working with partners. And one of that is through health department support. We provide direct funding to health departments. We have a small pot. Most of it goes out the door, but it's still, when you cut it up into 59 pieces of the pie, it's small. So each health, we've got 49 states, DC, Puerto Rico, and 8 large cities, and they're each receiving what I would consider below floor funding. It's about $315,000, which is a couple of FTEs. So tremendous respect and appreciation for the work that they're doing. And obviously, we hope to right-size that as soon as possible. In addition to financial support, we'll also support them with technical assistance. We fund a technical assistance provider, NASDAD, but we also provide programmatic guidance in support of elimination. And that includes how to build a cascade using surveillance data, how to conduct surveillance and case management. 70 health departments contributed to that middle document, and a number of other documents as well. We're also trying to utilize the data that the health departments submit to us to make it actionable. So putting them into data dashboards, quarterly surveillance reports, and giving real-time feedback. We fund both community and also medical training providers. So on the right, for example, we fund Medscape to do kind of some CME activities, and also University of Washington, who publishes both Hep C and Hep B online. And if you haven't seen those, I would definitely suggest you go on there. It's a wonderful primer. And then communication projects as well. And we have a great policy and comms teams. One thing I just wanted to mention is, while I'm going to kind of lean into Hep C right now, it's extraordinarily important that we're looking at whole person health. So when we're looking at the risk factors of not only acquiring new viral hepatitis infections and other infectious consequences of injection drug use, it's really important that we're looking at comprehensive services. There was a study recently, and I'm sorry, the graphic on the right didn't show up, but there's an estimated now 3.7 million people who inject drugs. And this was an estimate based on injection drug use within the last year of survey. That is a very high percentage of our adult population considering, and 32% indicated that they were regularly sharing injection equipment. So as we look at addressing, preventing, diagnosing and treating, we need to make sure that we're really working with the communities that are supporting people with a current or past history of substance use. So we were not first to the game, that's for sure, but we are investing and really supporting harm reduction. So we're very proud. We are supporting through a funded partner 75 syringe service programs in 34 jurisdictions to implement core and expanded services. We fund another partner to conduct a national survey of syringe service programs. And we're also funding 18 health departments through a separate kind of competitive model to implement a PWID service bundle. And again, C, heavily burdened. 40 to 70% of people who use and inject drugs are estimated to have had past or present Hep C infection. 20 to 40% current, but clearly HIV, STIs, and as I've shown, B and A are also infectious consequences. So we need to make sure that we're addressing it holistically. And there will be benefits as we lean into this to the other hepatitis. For example, there was a study listed here looking at people with Hep B listed as a cause of death from 2010 to 19. And you can see in that intersection, about a quarter had Hep C infection, and just over 5% had HIV. So if we're leaning into this space, we're going to have benefits of other. Also, we've seen sporadic HIV outbreaks among people who use and inject drugs. And as we work with Division of HIV Prevention, and they work with state and local health departments to investigate it, we're finding, just like in Scott County and all the other handfuls of these, that when there's an HIV outbreak among people who use inject drugs, the background prevalence of Hep C is about 90%. And if you look at the graph on the right, the Hep C precedes the HIV acquisition, often by months to years. So there is a huge opportunity for HIV diagnosis, and then syringe service programs, substance use disorder treatment as prevention for HIV acquisition as well. And this just shows some of those interventions I mentioned and the impact on overdose mortality, all-cause mortality, HIV transmission, and Hep C transmission. So again, we need to be working in partnership across programs. So what about C? And this is where I wanted to kind of spend the last few minutes in terms of looking forward. We know that that's our biggest burden. And we also know that if we address C, we're going to also have a positive impact on other things as well. So we've got universal screening recommendations. AASLD and IDSA recommend treatment for essentially everyone. I mean, not kids less than 3 at this point. And treatment in pregnancy is currently considered a shared decision-making process while there's additional clinical studies going on. But really, pretty much everybody should be getting treated. So are they? Well, we looked at this study using pharmacy claims data, and even though in the first 7 years after the new generation of DAAs were released, it showed that more than 1 million people had been treated, you see the treatment rates declining. And it might be easy to assume that perhaps most of the people who needed to be treated were treated, but that's far from the case. We looked at using a large claims database in 2019 and 2020. People who were diagnosed with Hep C, so this doesn't even include the 32% of people undiagnosed, and who were continuously insured. So this should be the low-hanging fruit for timely treatment. Only a quarter overall were actually accessing timely treatment, and the rates were even lower, 1 in 4 for people for Medicaid recipients. We looked at another analysis, this time using commercial laboratory data and including people without insurance, and the rates were similar. But if you look at adults less than 40 or people without health insurance, or you combine those, you see the rates are even lower, 1 out of 6. This was the transformative treatment that was supposed to change the landscape of Hep C. And a decade afterwards, far too few people are actually accessing treatment. So who is currently living with it? We've treated a lot of the baby boomers, the Medicare recipients, but I will say even in that prior analysis, the highest group were individuals over 65 with commercial insurance, and the timely treatment rates were only 48%. So we're not doing great in any group, but this shows that in terms of prevalent infection, the highest groups are people with no insurance and with public insurance. It's not surprising, although super concerning, that despite over 1 million people treated, our prevalence rate is essentially unchanged. And so you can see in the orange that the most recent prevalence estimate using the NHANES household survey is still at about 2.4 million. And when you account for that up number of people who use and inject drugs, they suspect that it actually might be closer to 4 million. So we've got to address the barriers, and there's a lot of them. But I think the biggest thing is making sure that we have affordable treatment for everybody, regardless of insurance status, and services available in the settings where people who have Hep C receive care, even if that's brief encounter settings. The model of diagnosing in a longitudinal primary care center and sending somebody to a referral, like an infectious disease or hepatology specialist, is not going to get us where we need to go. Some of the highest impact settings that we feel like are going to help us move the needle are listed here. So syringe service programs, MOUD programs, and then also carceral settings. A third of people with Hep C have been estimated to, because of the confluence with drug-related charges, to go in and out of a carceral setting in a single year. So it's a huge need. These are certainly not the only settings. I mean, I just think in terms of a hospital medical center, emergency department, your inpatient setting. These are opportunities for diagnosis, treatment initiation, and vaccine. At least get them started. There's a great model at the University of Kentucky. It's a 5 pharmacist-based team, and they are not even diagnosing in the ER. They're getting people who come in through the ER already with the diagnosis, but not with the treatment, and then linking them through this pharmacy-led model to treatment. And they've lowered the number of days to linkage from like a year to like 6 days. So it's extraordinary. There's some great models out there. But nationally, to really scale up and expand on these kind of sporadic models of success, we need a transformative national plan. And fortunately, one has been proposed at the highest levels of government. So Dr. Francis Collins, who is the former director of the National Institute of Health, who then became science advisor for President Biden just on a temporary basis, has had the opportunity and been provided the green light to work to establish the kind of blueprint or framework for a national Hep C elimination program. It's got 3 pillars: diagnosis, treatment, and comprehensive public health implementation. I will say the treatment, it would be a federal drug procurement model, kind of a Netflix model, which was like used in Louisiana and Washington State, where the federal government would put a certain amount of price cap and then purchase unlimited quantity of treatment. And it would be free treatment for uninsured, Medicaid recipients, and anyone in a carceral setting. So obviously the drugs are critical. They're also not sufficient. So you need to wrap that around with comprehensive public health implementation. An update on that is just that you have to have a Congressional Budget Office score. You see the most effects in terms of cost savings about 20 or 30 years down the road, but CBO looks through a 10-year lens. Fortunately, preliminary analyses still show that it's very cost saving at that point. It's currently being considered, but obviously nothing is across the finish line. While we're waiting for that, there are still things that are in the proposed initiative that we can do with modest amount of funds. Maybe not the drug procurement and maybe not comprehensive public health implementation, but diagnostics provides a huge opportunity. And right now we're a little hand-tied by this 2-step antibody first approach. An antibody only tells you if you have past or current infection. It doesn't tell you whether you're currently infected or in people who have cleared either spontaneously or through treatment, whether they've been reinfected. So you have to have an RNA, but far too few people aren't even getting diagnosed. And then those who are getting diagnosed, many of them are not getting completely diagnosed. Additionally, there's some limitations of the 2-step because you're missing a long seroconversion window period. So, just thinking of HIV diagnosis when it was accelerated, like 2nd generation, 3rd generation, 4th generation antibody, and then it was antibody with P24 antigen, trying to get it as narrow as possible. We have like a 6-week window between antibody detection and RNA. So there's an opportunity for RNA first testing, or there's other tests out there like core antigen testing that are available outside of the US. So in order to bring these tools to us, we want to look at not only potentially viral first testing, but viral point of care testing. So you could have same day test and treat. So until recently, there were no point of care tests available in the US, although there are outside of the US. And we recognize the benefit of it, increased access to treatment at shorter duration. So in working with the NIH's ITAP program, the Independent Test Assessment Program, which was stood up during COVID to rapidly develop point of care tests, they then pivoted to Mpox, and now they pivoted to Hep C, which is great. So we've been working with them for the last 1.5 years. And just this June, we got marketing release of the first RNA point of care. It's long awaited and much needed, but it's not a panacea. It's still a platform-based test. It can take 60 minutes to run, but it does avoid laboratory services, phlebotomy, and it can get point of care if the individual will stick around for an hour. There are a lot of questions about implementation, some of them that are listed here. I am not going to go through them, but I do want to point you to a new document. It's a considerations document that we just released on our website. As we envision a same-day test and treat approach for Hep C, we realize there are still some additional tools we need. For example, a Hep B surface antigen. So we've got rapid point-of-care pregnancy tests, HIV tests, and Hep C tests now, but we still don't have a Hep B surface antigen. And so we've now working with ITAP they've put out and closed a solicitation, and they're going to begin validation studies for a Hep B surface antigen point of care. We hope to have that. It's conceivable it could be available in the US by the end of calendar year 25. And this is just a little bit more about that. I'm going to close there. There are so many other things that we could talk about. I didn't even talk about DAAs in pregnancy or long-acting injectables or vaccine research. But I will just say there is a huge opportunity and a huge need. And there's a huge intersection in the work that we're all doing, whether it's HIV, STIs, viral hepatitis, or working with people with a history of past or present substance use disorder. So Tennessee is unfortunately still in the real midst, the hot spots of this area. So grateful for the opportunity to be with you today, grateful for the opportunity to share this work, and really grateful for all the work that you're doing. Thank you.